Welcome to Lecture for Abnormal Psychology. We'll be talking about anxiety disorders today. We'll talk about overview of anxiety, some essential features common to anxiety disorders. Talk about the etiology of the disorders, and then we'll talk about the disorders that are grouped in the group currently identified as anxiety disorders, separate from obsessive compulsive related disorders and trauma related disorders. So that includes generalized anxiety disorder, panic disorder, agoraphobia, specific phobia, social anxiety disorder, formerly social phobia, and separation anxiety disorder and selective mutism as well. Okay, so starting off with some terminology. What's the difference between fear, anxiety, worry, and panic? Well, fear is an emotional response to real or perceived immediate danger, right? So either there's a bear there, it's going to eat you, and you experience fear. You have this reaction, subjective experience, you have thoughts about it, and you have a physiological response. And it's usually fairly short-lived. You stop feeling afraid after something happens. Either you run away or the bear eats you. Either way, you're done feeling fear after a pretty short amount of time. Anxiety is a more diffuse emotional reaction that's associated with either, most commonly, anticipation of future problems, or it could be associated with thoughts about or rumination about past problems, right? So typically not as intense a feeling as fear, more a little lower level, but also more kind of spread out, diffuse, and longer lasting, right? It can hang in there longer for you. How's that different from worry? Well, worry is just the cognitive component of anxiety, right? Because anxiety, again, has a cognitive component, has a subjective emotional component, has a biological component, and worry is just that one cognitive piece of anxiety. So what about panic? Panic, we flip back up to fear. It's just a whole lot of fear. So it's really about severity and also kind of timing. Sudden, intense, overwhelming fear is what we refer to as panic. Okay, so ways that anxiety can be pathological. Now it's broken up into your anxiety disorders, which we'll talk about today, and then later we'll cover obsessive compulsive and related disorders like OCD, trichotillomania, body dysmorphic disorder, excoriation, which is skin picking, and hoarding disorder, and then also separated out are trauma and stress related disorders like PTSD, acute stress disorder, reactive attachment disorder, disinhibited social engagement disorder, and then adjustment disorders. Okay, but again, we'll focus on that first grouping right now. And it used to be most of these were all under the same banner of general anxiety disorders. DSM-5 separated them out into these different categories, largely based on research looking at differences in neurological functioning, as well as some more recent research on heritability, where we think, okay, well, these things seem to kind of run together, and these other ones seem to run together, but they seem to be different from each other. Okay, so when we talk about etiology for anxiety disorders, and this kind of goes broadly for the anxiety disorders, the obsessive compulsive disorders, and also the trauma-related disorders. An important question before we get too far is to think about what causes anxiety versus what causes an anxiety disorder, right? Because typically we think, well, what's the etiology of this anxiety disorder? Oh, why are you feeling anxious? But you got to stop for a minute and think, well, doesn't everybody feel anxious to some degree? Isn't fear, anxiety, panic, worry, aren't those somewhat normative? Yeah, they are. And there's reasons that you have them. It's important to understand those reasons. But they become pathological, again, whenever they're of greater severity than is appropriate, or greater duration, right? They're lasting too long, or they're kind of false signals. They're disproportionate. You're having more fear than you should, given the thing that's in front of you. Because again, the etiology, the reason why you have these things, typically, it's adaptive, right? You have that fear and panic, usually kind of fight or flight response, whenever there's a real danger and your body needs to motivate you to get up and go do something, get out of here, right? It speeds up your heart rate, speeds up your breathing, all that stuff. Well, that's very helpful. There's kind of some evolutionary advantage to that. Same thing with anxiety. It can be argued that anxiety has its advantages, right? Because if you have too little anxiety, too laissez-faire, then you're not vigilant, right? Because anxiety increases that vigilance. Oh, I better be on the lookout. Like, I'm not afraid. There's not something here now, but something might be here, right? I heard that twig snap. I'm not afraid, but I'm anxious. There might be a bear. And so I have increased vigilance, and I don't have quite the same physiological response as fear, but there are some things that are gearing up in terms of getting systems online and ready. So there's some advantages for anxiety and fear, and even panic, I would argue. But sometimes, like I said, it becomes pathological whenever it's too much, lasts too long, or is inappropriate to the situation. Okay. Either way, there's biological contributions to anxiety, both through normative, non-pathological anxiety as well as pathological anxiety. There's growing evidence that there's separate genetic vulnerabilities for being kind of generally anxious and tense, right? So there aren't genetic vulnerabilities per se for specific disorders. Oh, you're not at risk for having GAD, but you may kind of inherit a tendency to be more anxious and more tense. But that seems to be different than this kind of inherited tendency to experience panic and panic attacks, panic-like symptoms. Even though those are a related phenomenon, they involve kind of different neural circuits, and so not surprisingly, seem to involve different groups of genes. And again, when we talk about the genetic vulnerabilities here, we're talking about polygenic inheritance, multiple genes being involved, not just a single one. In terms of the neurology, the brain circuits involved, when we talk about anxiety and fear, a lot of what we're going to talk about has to do with the limbic system, right? And that's those midbrain structures, which are the go-between between the kind of more primitive hindbrain and the more advanced forebrain, mediating these signals from bottom up and top down, right? Where bottom up you have these signals coming from the hindbrain saying, okay, I'm having trouble breathing. There's not a lot of air here. Something may be wrong. Sends it to the limbic system for processing to motivate you to, hey, you should be afraid right now. Do something about this. Send the signal up to the forebrain. Hey, what are we going to do? And then the forebrain makes the plan to, get out of that cave or whatever it is. But anyway, the limbic system involved with emotion. A couple of neural circuits that there seems to be some evidence about are involved with anxiety disorders. One being the hypothalamic pituitary adrenal axis, right? So you have the hypothalamus sending signals to the pituitary gland, sending signals, and that's both in the brain, sending signals down to the adrenal glands, which sit on top of the kidneys, and the signals coming back up, right? So this kind of back and forth system. Excuse me. One important thing to keep in mind about these brain circuits, these kind of neural circuits, is that there are changes in sensitivity in neural circuits. And in looking at a particular, when two neurons meet at a synapse, how a neuron responds to a presynaptic neuron, it changes over time, right? Where we talk about change in sensitivity, think about one neuron trying to communicate to the next. It's releasing these neurotransmitters. They're diffusing across the synapse, binding and causing a neuron to fire or not fire. Right? So whenever a neuron is more sensitive, you need fewer neurotransmitters involved in sending the message. Right? It can depolarize pretty quickly and send the message very efficiently. Once it becomes less sensitive, okay, well now we need more neurotransmitters there to send the message. Right? And these changes in sensitivity are things that happen via a variety of things. One is just the activation of that circuit over time, right? You repeatedly activate that circuit, that can cause change in sensitivity. And we still don't really understand why, but those changes can go both ways, right? You can have down regulation and up regulation, right? So it's kind of like you can be anxious, run that circuit a bunch, and it gets less sensitive because it's getting worn out, or it can get more sensitive because it's getting worn out, right? So kind of chronic anxiety or large amounts of anxiety traumas can change the sensitivity of those circuits to where now smaller events can lead to the same amount of anxiety that previously took bigger events, right? Think about those events being inputs that should typically cause those circuits to turn on. Well, over time, if you have lots of stressful events or really big stressful events, maybe you need less stress to cause the anxious or fear or panic response. So experience changes sensitivity. So too does maturation, but so too does the introduction of psychoactive chemicals into your brain. So if you're doing any kind of drugs, and not just the the illegal ones, also nicotine, caffeine, alcohol, those things have chemicals that cross the blood-brain barrier and can change the sensitivity of these neural pathways and can cause changes in anxiety, which obviously that's taken advantage of from a pharmacological standpoint, where they're going to prescribe you drugs to change the sensitivity of these pathways oftentimes, right? So they're not just giving you more chemicals, they're trying to upregulate or downregulate neuronal transmission by exposure to these chemicals. Okay. In addition to kind of biological contributions, there's also psychosocial contributions that are important to keep in mind. One of the big ones is another important contribution would be attachment style, right? So how responsive parents are to their children in times of need, when kids are hungry, tired, sick, need a diaper change, whatever. Especially the first 3 months of life is when it's super important, always important, but the kind of parental responsiveness influences brain development in such a way that children develop a kind of this characteristic attachment style, this pattern of responding to stress. And that also influences, according to Bowlby, these internal working models about the self, about others, and the world, right? Where if you have a secure attachment, you start to believe, I'm good, my parents are good, and the world is generally a safe place. And if you have an insecure attachment, different types of insecurity, but generally that might be, I'm not good, my parents aren't good, they're not to be trusted, and the world's a dangerous place. Right? And the type of attachment style that develops often depends on the responsivity of parents, right, to a kid's needs. And it's one of those things where it's kind of like Goldilocks, right, where you can't be too much and too little. It's got to be just right, right? You don't want to protect a child from all negative experiences, keep them ever from experiencing anxiety when they're young, because eventually they will experience anxiety, and if they don't ever face it, they won't have the tools to deal with it. But if you just let them go wild and they're experiencing anxiety and you never help them, then they begin to think, okay, I'm helpless and they're not going to help me. The world's really dangerous, right? So this is kind of balance where you want to establish this secure base that kids then can explore from, kind of get into some trouble, maybe get a little hurt now and again, but always be able to come back and be taken care of. So those early experience with parents can be really important. And then just generally learning plays a role in the development of anxiety and anxiety disorders. Some of it comes from parental modeling. So when parents talk about what they're scared of, whenever they react to phobic stimuli, when they see a spider, what do? Kids are watching and they learn what they should be scared of and how they're supposed to react, right, to some degree. And then also classical and operant conditioning play some roles with anxiety disorders, and we'll talk more about that. I'll save that for when we get to specific phobias, because that's where it's probably most relevant. Okay, looking at the anxiety disorders, generalized anxiety disorder, it's DSM-5 diagnostic criteria. Essential feature is 6 months of excessive anxiety or worry about a number of things, right? So this is, and usually, it's 6 months is the minimum. Often there's people, whenever you interview them clinically, they say, oh, I've always been this way. Yeah, I can never remember a time when I didn't worry. They often characterize themselves as, oh, I'm a worrier, I'm a worrywart. That's how I am. They kind of see it as part of their personality. But in addition to this excessive anxiety and worry, right? So that's, and you may think, well, if somebody has a lot going on, it's a rough year. Yeah, they may have that. True. But one of the things that really sets people with GAD apart from other people who are just having a rough time is this next criteria, which is they report significant difficulty in controlling the worry, right? So they don't want to worry, and they feel like they can't do anything about it, right? Oh, I just can't stop worrying about this. I can't get it off my mind no matter what I do. Whereas other people who may be experiencing stressful events, it's really stressful, but oh, I'm going to take a break from this. I'm not going to think about it right now. I'm going to go do a Netflix binge. I'm going to take a vacation, whatever. People with GAD have a really hard time doing that and report this kind of subjective experience of difficulty controlling that worry. And again, where worry is that cognitive component of anxiety. So they have a hard time not thinking about it. You've got to have 3 of 6 possible symptoms. Right? They include restlessness, being easily fatigued, having difficulty concentrating, irritability, muscle tension, and sleep disturbance. Of those, I'd say muscle tension is one of the kind of cardinal symptoms. It's one that's reported by the majority of people with generalized anxiety disorder, and it probably influences some of the other ones, right? It's like being easily fatigued. Think about if you have chronic muscle tension where your muscles are always tight. It's almost like you're always working out. Yeah, of course you're going to be tired. That's just one symptom is a consequence of another. And then the worry causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And of course, like most disorders, is kind of rule out that it's not caused by drugs, right? And this is in terms of not being caused by drugs, it means it's not that, oh, you took drugs and now you have the disorder. It's that these symptoms aren't being caused by the drugs. You're not being anxious because you're on coke, right? The symptoms aren't caused by the short-term effects of a drug or an illness, and they're not better explained by another disorder. Okay, some background info on GAD. It's rare but common, right? So when I say rare, well, not everybody has it, but it's one of the more common anxiety disorders. 12-month prevalence rate around 3%. The lifetime prevalence rate somewhere between 5.7 and 9% of the population in the states. So again, one of the more common anxiety disorders, but still, in a room of 100 people, at most maybe 9 would have had that diagnosis at some point in their life or will expect to experience it at some point in their life. More common in females than in males. Like a lot of anxiety disorders, it's like a 2-to-1 ratio, so like 2/3 of them, of the people that present will be female. More common people of European descent than non-Europeans, and also more common individuals from developed countries than non-developed countries, which is interesting, a cultural piece there. The 12-month prevalence rates vary across age groups. In terms of causes, again, there's probably a general biological vulnerability. There's not a predisposition to the disorder itself, but there probably is some sort of genetic, neurological predisposition, vulnerability to being anxious, being tense. Also, there's this tendency in these people to focus on the cognitive aspects of anxiety and avoid the other aspects. And that may be a learned thing, that may be a personality trait, right? And then the third thing would be there tends to be a belief in the dangerous world and a need for vigilance, right? Like I've got to worry because if I don't, it's all going to fall apart. I got to keep juggling all these balls because if I don't, they're going to hit the ground, and they can't hit the ground. You understand me, right? And so that belief that they have to do these things, and if they didn't worry, something bad would happen. And it's not kind of if I don't worry, my parents are going to die. It's kind of more like an OCD type catastrophized thing. But just, oh no, it will be bad. Just this general diffuse, it will be bad if something happened. So I have to be sure that I keep an eye on the bills and the kids and the thing and all the different things that they are worrying about. In terms of treatment, psychopharmacology, the drugs, good for short term, but dangerous beyond that, right? And they're often recommended to the drugs that are used, like benzodiazepines. Don't prescribe them for more than a week. In practice, people get on them for much longer than that, which is unfortunate because they tend to be, there's a danger, they're habit forming, they're addictive, and especially for older adults. For older adults, those drugs, the benzos, They hit them harder for a variety of reasons involving metabolism, but it also causes greater sedation and motor coordination difficulties, which leads to greater fall risk, which is a really significant thing in older adults, because if you fall and break your hip, that could be it for you if you're, in your 80s. So again, the drugs are really good at stopping anxiety in the short term, but they do not cure generalized anxiety disorder, and you can't stay on them forever. You can't just keep doping yourself. It doesn't make the worry go away. It just makes you not mind the worry for a while you're stoned. Cognitive behavioral therapy is pretty effective for this and most anxiety disorders. CBT with this disorder is going to focus on challenging thoughts about danger and kind of cognitive distortions about catastrophization, where you teach people to ask themselves the questions, okay, so you're worried about this. What's the worst that would happen if this happened? What are the odds that this would happen? All those kind of questions that they can ask themselves. And then another kind of approach that people have been moving toward recently has been kind of this increased use of mindfulness, right? Where you get people to focus on the here and now. And a lot of that with these folks, you think, well, they're very focused on here and now. No, they're not. They're focused on the future. I'm worried about what's going to happen. So we're trying to get them to shift to what's happening here, right now in the moment, rather than what's going to happen tomorrow or next year or 10 years down the road. That can be helpful. And along with that, when you're developing those skills, mindfulness skills, one of the other things that it helps with is distress tolerance, right? So, okay, you're worried about this, and that makes you uncertain. And when you're uncertain, you don't feel good, and then saying, okay, that's fine. Don't feel good. Sit with it. Don't try to not feel good, right? Don't try to stop the feeling bad. Just be okay with it. If you accept it, maybe it'll go away. It'll be less. It's part of it is the being so upset about worrying, that difficulty controlling the worry is kind of this makes you worry more. Oh, now I'm worried about the worry, right? So if you can just let go of some of that, maybe the other things won't be so bad. Okay, panic disorder, characterized by recurrent, unexpected panic attacks, right? Where a panic attack is the experience of an abrupt and intense fear with at least 4 of the following symptoms in this brief period of time, right? Where you, in a couple of minutes, you have this huge uptick in fear, and then it typically comes back down pretty quickly too. Increased heart rate, sweating, trembling, shortness of breath, feelings of choking, chest pain, GI distress, which may include nausea, dizziness, chills or feeling feverish like you're hot, paresthesia, which is kind of a tingling, in your extremities, derealization and depersonalization, where you feel like either you're not real or the world's not real. Like, oh, it feels like this is like a TV show I'm watching, or it feels like I'm a ghost walking through these halls, or fear of going crazy or fear of dying. So obviously a lot of these symptoms, thinking about the chest pain, the shortness of breath, not uncommon when people experience a panic attack that they think, I'm having a heart attack, because there's a lot of symptom overlap, which again, once you think you're having a heart attack, that's going to scare the crap out of you too, causing you to have more anxiety and fear and more panic. So, but having a panic attack isn't enough to have panic disorder, right? Because you can have panic attacks with no disorder. You can also have panic attacks in the course of other disorders. What makes something panic disorder is this kind of next criteria. That at least one of the panic attacks was followed by 1 month of at least one of the following of the 2 things. Either concern about additional panic attacks or their consequences, right? So you have a panic attack, and then for at least a month you're worried about, oh, what if I have it again? What's going to happen? What am I going to do if I'm grocery shopping and that happens? What do I do if I'm at work and I start to freak out and people are staring at me? Right? So at least a month of concern, or a significant maladaptive change in behavior related to panic attacks. And this is typically avoidance, where again you're kind of worried about it happening again. So, well, I'm just not going to go to work today. Oh, I can't drive. What if I'm driving and have a panic attack? I'll crash. Okay, well, if you're going to live in Texas, saying I'm not going to drive, that's a fairly maladaptive change in your behavior. You're not going to get around, too long without driving. Uber's pretty expensive. And then, of course, you got the rule outs, and the symptoms aren't caused by drugs or illness, or better explained by another disorder. And as I said, remember that panic attacks can and do occur in the course of other disorders, and you can even add, there's no, for DSM-5, you can add a specifier to any other diagnosis to note the presence of panic attacks, if you meet the criteria for what a panic attack is. Okay, 12-month prevalence rate, it's not as common as some of the things we talked about before. 2 to 3%, lifetime prevalence 4.7%. Again, still more common in females, like at a 2-to-1 ratio, females to males. Causes, again, some genetic vulnerability, which seems to be different than the genetic vulnerability for generalized anxiety disorder, right? So if you have a parent that has generalized anxiety disorder, okay, you may be anxious, but you're not necessarily more likely to have panic. Whereas if you have a parent with panic disorder or panic attacks, okay, now you're at increased risk for developing panic attacks at some point in time, and possibly panic disorder. Now, whether or not you develop panic disorder after having panic attacks, to some degree, relates to the degree to which you experience this interoceptive avoidance, right? Where interoceptive being kind of internal to your body, those internal experiences of when you sense your heart rate, when you sense your stomach tightening or gurgling. Some people are really sensitive to those things and they attend to them, and some people are really bothered by them and they avoid those sensations, and it scares them when they have those sensations. And if you're freaked out by your bodily sensations, well, then that increases the risk of developing panic disorder, because you may misinterpret, a stomach flutter to be, oh, here's a sign that something's wrong. Here we go, panic attack sets in. In terms of treatment, again, drugs are effective at stopping panic attacks. Right? If you're having a panic attack, take a Xanax. Pretty soon you'll be fine. Well, you won't be fine. You'll be asleep on the couch. And again, there's this addiction danger. These drugs that work for anxiety tend to make you feel pretty good, and who doesn't like feeling good? And whenever you have a drug that makes you feel good, it has a high addictive potential. So there's a danger there. But luckily, you really don't need them. Maybe short term, and for kind of people that are worried about going out, giving them a prescription where they kind of have that pill in their pocket, that can sometimes be enough to get them to the next step. And the next step is typically some sort of therapy that involves exposure therapy, in this case, interoceptive exposure. So that interoceptive avoidance, interoceptive exposure is where you're going to expose people to these internal bodily signals, right? So you get people to experience increased heart rate, get them to hyperventilate, right? So you have a client breathing into a paper bag or running up and down the stairs to get them to have these bodily sensations, and then go, okay, you feel this? Your heart rate's going? Tell me what you're thinking. And like, oh, I think I'm having a panic attack. And you go, okay, now remember what we talked about. This is just my heart beating fast. This is the sympathetic nervous system cranking up. Pretty soon, the parasympathetic system is going to turn on and shut this down, and my heart rate will slow down. If I just wait and count to 10, let's see if my heart is any slower. 1, 2, and you go through, and yes, it's a little slower now. Not normal yet, but it's getting there. If I keep waiting, it's going to, so you get this self-talk. You expose them to these internal stimuli, and then get them to realize that it will pass, right? And once you can get people to realize that, yeah, when you experience this panic, it comes out of nowhere. Again, it's unexpected. It's not that you saw something scary and you had this panic. It's out of nowhere. You're having this terror symptoms. Once you get people to realize that, yeah, okay, you're having it, it's going to be fine. It won't necessarily stop them from having panic attacks completely, but it will reduce the intensity of panic attacks, and it will reduce the frequency. They will have them less often, which is pretty cool. Okay, related to that is agoraphobia. Used to be in the DSM, you had panic disorder with or without agoraphobia. It was kind of tacked on together as one disorder. Now they've been separated out as two separate disorders because you can have one without the other. For agoraphobia, it's marked fear or anxiety about 2 or more of the following situations: using public transportation, being in open spaces, being in enclosed spaces, being in a crowd or in a line, being outside the home alone. Okay? So the person fears or avoids these situations because of thoughts that escape might be difficult or help might not come. And again, this is mostly about when it happens co-occurring with panic disorder, it's about I don't want to be in this space because I might not be able to get out if I have a panic attack, or it might be embarrassing if I have a panic attack, so I'm going to avoid the situation. So if you have this fear or anxiety in 2 or more situations, could be an additional diagnosis of agoraphobia. And again, the situations are almost always provoke fear and are avoided, or if they're not avoided, they're endured with significant distress and may require the presence of a companion. The fear that they experience is disproportionate to the thing. So, oh yeah, I'm scared of going on a SpaceX rocket to Mars. Oh, that sounds like agoraphobia. No, you should be scared. The thing might blow up. But if you're talking about kind of typical everyday things, you really shouldn't be that scared of that. Okay, then yeah, that may be agoraphobia. So the fear is disproportionate. It's been present for at least 6 months, and again causes clinically significant distress or impairment, not accounted for or better explained by another disorder. Okay, so about half the people diagnosed with panic disorder will have co-occurring agoraphobia. Agoraphobia does occur without panic disorder, but fairly rarely, at about 1.4% of the population lifetime prevalence. And again, like a lot of anxiety disorders, twice as common in women than in men. In terms of causes, obviously, it almost always occurs subsequent to a panic attack. Even with somebody who has agoraphobia without panic disorder, well, they may not have panic disorder, they probably had a panic attack at some time, right? Or panic-like symptoms that maybe didn't rise to the full criteria of a panic attack. But anyways, they had some experience where they freaked out, and now they don't want to go places because of fear of freaking out and not being able to escape or being embarrassed. There's some cultural differences in the development of agoraphobia. So although we see some similarities in prevalence rates for panic disorder across cultures, across geographic regions, there's more variability in agoraphobia, which there seems to be some kind of cultural rules about if it's okay to be in public and be embarrassed or not, and if you should endure this anxiety, yeah, just go ahead and do it, or no, it's better to save face and be safe at home. In terms of treatment, it's largely exposure, kind of in vivo exposure, right? So you're scared of being in public, okay, we're going in public together. But again, a lot of times when you're doing exposure work with any kind of anxiety disorders, you're not going to just take people out to face the thing they fear straight up. You're typically going to prepare them first, teach them some coping skills about how to bring their anxiety down, deep breathing, imaginal exposure, kind of guided imagery, things like even like yoga, giving people the skills to realize they can control some of their bodily responses to anxiety, teaching them some giving them some cognitive tools, and then, okay, now you got some tools, let's go face the fear, because once you face the fear loses its power. Okay, specific phobia. Marked fear or anxiety about an object or situation. The phobic stimulus almost always provokes fear and is avoided, again, or is endured with marked stress and may require the accompaniment of a companion. The fear is disproportionate to the actual danger that you're facing, lasts at least 6 months, and causes clinically significant distress or impairment. And again, symptoms aren't better accounted for by another disorder. And then for specific phobia, you can specify the type. If it's animal, you're afraid of spiders, snakes, natural environment, heights, blood injection injury, it's usually people afraid of needles, situational, being in certain situations, or other. Now the thinking when they have this kind of specify the type was, we're going to see different courses of the disorder, maybe different genetic vulnerabilities, different responses to treatment, and not so much happened. Really, blood injection injury seems to be different than the others. Other than that, they all kind of clump together, right? Because for animal, natural environment, situational, other, whenever the phobic stimulus is there, you get this kind of arousal, heart rate increases. For blood injection injury phobics, though, you get the opposite. Like this vasovagal response, where instead of amping up, they turn down and may even faint or pass out. And so that seems to be kind of a different thing than the others. But there doesn't seem to be, so far, meaningful differences between the animal type and the natural environment type. But it should be noted that people are more likely to develop phobias to some things than others. Right? It's easier to learn to be afraid of things that are actually dangerous in nature than things that are dangerous that are a bit newer, which suggests maybe some evolutionary things built into these phobias. That may have some prepared learning, where it's easier for us to learn to be afraid of a snake than it is to develop phobias of guns, right? Whereas arguably guns are more dangerous than snakes. But again, if our ancestors weren't dealing with guns, then maybe we didn't develop those neural patterns to kind of set the template to be ready to be scared of it. Okay. This is the most common anxiety disorder that we'll talk about. 12-month prevalence rate of 7 to 9%. Lifetime prevalence rates up to 12.5%. So fairly common. Again, more common in females. Interesting here, more common in Hispanic individuals than non-Hispanic whites. Not sure what that's about, but interesting. In terms of causes, I told you we'd come back to kind of classical conditioning, right? So when you acquire a phobia, and acquire means, okay, you didn't used to be afraid of this thing, now you're afraid of it. One theory, a prominent theory, that acquiring a phobic pattern happens via classical conditioning, right? Where you're not afraid of something, and then you're exposed to something that is scary, where you have a fear response, and the phobic stimulus is also present. And so it could be that, you're not afraid of dogs, but then one day a dog is barking at you and trying to bite you, and it really scares you. Okay, and now you've developed a phobia of dogs. Or it could be, you're petting a dog, and while you do, there's a loud explosion at the chemical plant next door. But the dog was what you're focused on, and now the dog becomes associated with the fear you experienced with the explosion. So the dog wasn't scaring you, but you're scared while being with the dog, and now you've acquired the thing, the connection that way too. Either way, there could be this kind of pairing of what's previously a neutral stimulus with this phobic response, where you acquire this fear response via classical conditioning. But what we know about classical conditioning is, if you keep, once you have a conditioned stimulus, right, you ring in the bell, the dog's salivating. If you continue to present the conditioned stimulus without ever pairing it again with the unconditioned stimulus, so ringing the bell, the dog salivating, and you never hit the dog with the meat powder anymore, just bell, 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 eventually you ring the bell, dog's not going to salivate anymore, right? You'll have extinction of the relationship, right? The pairing gets broken. But we think that doesn't happen so much with phobias because of operant conditioning, right? So they don't get the chance for extinction, because once you get afraid of that dog, okay, if you just go hang out with dogs a bunch, you'll stop being afraid of them. Well, if you're afraid of dogs, I'm not going to hang out with them, right? One of the key features of phobia is avoidance of the phobic stimulus, right? And so you're walking on the street, you hear a dog barking, you start to get anxious, and you run away. As you run away, you feel better. When you're feeling better, that's rewarding, right? Removal of this aversive stimulus makes you feel better. So the behavior that's being rewarded, that's making you feel good, is the running away. So avoidance is rewarded, and so you're going to continue to avoid. If you continue to avoid, extinction can never happen. So operant conditioning plays a role in maintaining phobias. And as we alluded to early on, social learning probably also plays a role in the development in maintenance of phobias as well. So this is when people are seeing how other people react to these phobic stimuli, in terms of both being learning what they should be afraid of, how afraid they should be, and how okay it is to publicly display your fear of phobic stimuli, right? Which is social learning and gender roles may explain some of the variability, some of the differences in gender ratio here, where boys and men are often told explicitly that it's not okay to be afraid, and they're socially punished for exhibiting fear to phobic stimuli. So they may experience the fear and then just swallow it and not display it, which then ultimately may make them less likely to either report a phobia or maybe even to develop the phobia. Treatments, largely exposure-based therapies, right? Expose people to the phobic stimulus, right? Because that's what leads to extinction. But again, it's not a matter of somebody's scared of snakes and you do Indiana Jones, drop them in a pit of vipers. That'd be flooding, and it's fairly unethical. No, typically you do it carefully, teach them skills, and one way to do that is via systematic desensitization, right? Where you're building this hierarchy of phobic stimuli. So if you're afraid of snakes, okay, so a real snake would be the thing you're most scared of. That's at the top. We're not going to start with that. Let's start at the bottom. At the bottom is a picture of a snake. Okay, yeah, that freaks me out a little. Okay, let's expose you to that until you're okay with it. And then maybe a stuffed animal of a snake. And then watching a video of snakes running around, right? And you build your way up the pyramid to increasingly scary things slowly, where you're getting okay with it each step, and you're building toward overcoming the phobia. Social anxiety disorder, formerly called social phobia. This is where people have marked fear or anxiety about one or more situations where they are being observed by others. And the key feature here is there's this fear that one will be negatively evaluated. And so the feared situation or situations almost always provoke fear and are avoided, again, or are endured with significant stress. And the fear is disproportionate to the actual danger, lasts more than 6 months, and causes significant stress or impairment. And then you can specify if it's performance only, right? And this is kind of a change for DSM-5. It used to be you had social anxiety disorder would be if you had it in one setting, and you could add the specifier of generalized subtype if it was in multiple settings. They've kind of flipped it where the disorder is one or more situations, but you can specify if it's just you're anxious about speaking in public, right? Or baseball players, if a catcher has that fear of throwing back to the pitcher because they overthrew once and now they can't throw back to the pitcher because they think they're going to overthrow. That's that fear of people are going to see me, I'm going to do this stupid thing, and they're all going to laugh at me. That would be social anxiety disorder, performance only. Versus generalized is where people just generally are avoiding social situations because they think people are going to evaluate them negatively, make fun of them, laugh at them, which makes this look a lot like a personality disorder, right? Because it can be, especially if it's multiple situations, where if you always think people are going to judge you negatively, that looks a little different than phobia. But for some people, it may be helpful to conceptualize it as an anxiety disorder, as a phobia. It's the second most common of the anxiety disorders, right? Specific phobia being the first, social anxiety being the second most common. 12-month prevalence of 7%, lifetime up to 12.1%. Interestingly, this is the one anxiety disorder that has an equivalent gender not ration ratio, so about equal numbers of men and women. And it's also one that's more common in the U.S. than Europe. Most of the other ones, America and Europe, tend to be pretty similar, and then non-Western countries tend to have lower rates of most of these disorders. Causes, again, there's probably a general biological vulnerability. And then in terms of the psychological input, individuals with this disorder seem to at some point learn that what others thinks about them matters a lot, right? These are messages that they're getting either directly, explicitly from their parents, or from the parents modeling, where the parents seem to be concerned about what people are going to think about them. That kind of gets the idea that, you shouldn't look foolish in front of others. You must always watch what you say and what you do, and be careful because everybody's watching, right? If you have that kind of belief system, that puts you at risk for this disorder. In terms of treatment, again, like a lot of anxiety disorders, some type of cognitive behavior therapy is typically pretty effective long term. And in particular, a group-based therapy is really helpful for individuals diagnosed with social anxiety disorder, because they can practice their skills, right? Because the whole thing is being worried about being evaluated by others. So in a group, you can give assignments where you have to give a speech, role play that you're asking somebody on a date or making a new friend, and then people can tell you honestly what they thought about you, right? Which you don't get in public. You can't kind of do focus groups of, okay, how was that for you? Whenever I said this, what did you think? That's creepy in real life. But in groups, that's totally appropriate, and that's processing. It's part of what happens in a group therapy setting. So that tends to be pretty effective for this disorder. And then two other disorders that are included in the anxiety disorders grouping that we'll go into in as much detail. One being separation anxiety disorder. Right? So this involves a developmentally inappropriate and excessive fear or anxiety concerning separation from attachment figures. Now this is one that's interesting because for a long time it was thought to be kind of something that just occurred in childhood, right? And this is where that developmentally inappropriate part comes, because there's a certain part of childhood where it's developmentally appropriate to have some separation anxiety, right? When you're peaking at about age 1, right? When you have that stranger danger. But if that persists into later childhood, adolescence, or adulthood, in some people, it's not that it's persisting to adulthood, it's emerging in adulthood. And so this isn't about, necessarily, whereas with children, it's always about the parents. With adults, it's usually about a romantic partner or a roommate, where now they feel like they can't go out in public without them. And if that person leaves, they're worried that they're going to not come back, that something bad's going to happen to them, or they're going to disappear. And so they experience a lot of distress being alone. So this is something that's been moved around in DSM-5 and shifted to where, okay, kids and adults too. Interesting. The other one is selective mutism, right, where you have consistent failure to speak in social situations. And these are social situations where speaking is expected, despite speaking in other situations. Sorry. So this isn't people that don't speak at all, right? This isn't people that have communication impairments, where you might have like an autism spectrum disorder, where somebody has difficulty interacting socially, has some language delays. This isn't somebody who, we're talking about they're being asked to communicate in a language that isn't their primary language. There's somebody that can speak fluently at normal levels in certain situations, usually in situations where they're talking to a close confidant. So often this happens with kids where they can talk to their mom, and they'll whisper to their mom, pss, 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 but they can't talk in front of a group of people, right? They go to the restaurant, waiter says, "What do you have?" And the kid can't tell the waiter, just won't speak, but will, whisper to mom, and mom will then relay it to the waiter. And again, has to cause clinically significant distress and impairment, like all the other disorders. Okay. Take-home message about this first part of anxiety disorders. The anxiety disorders we talked about differ primarily according to the focus of the fear, right? So trying to figure out, is this GAD or panic disorder or specific phobia? Well, what are they afraid of, right? With panic disorder, they're afraid of having a panic attack. With agoraphobia, they're afraid of having a panic attack or panic symptoms in public where they can't get away. Specific phobia, they're afraid of a particular specific thing. Social anxiety disorder, they're afraid of being judged. So all these things are about being afraid of something and experiencing fear and anxiety related to something, with the exception, I guess, of generalized anxiety disorder, which is, worry about everything. But generally, that's one that's not focused. All the other ones, depends on what the fear is focused on, that'll tell you which disorder fits the best with someone's experience. In terms of the causes, there are clearly some biological and psychological vulnerabilities, right? And there's different brain pathways involved in different aspects of fear, panic, anxiety. So not surprisingly, some differences in the heritability of different aspects of anxiety versus panic, let's say. But again, these vulnerabilities aren't specific to a disorder. they're a lot looser, a little rougher. There's these psychological vulnerabilities, which often have to do with beliefs that people develop about themselves, about the world, about control, about what should happen, kind of rules people set up in their minds. But whether or not anybody develops a disorder that has some level of vulnerability often depends on stressful events, right? Stressful events often precipitate the development of these disorders. So oftentimes we think about things like PTSD, post-traumatic stress disorder. Oh, here's a trauma, and then disorder happens. Yeah, but a lot of times there's could be a trauma or something that's traumatic that doesn't quite meet the DSM definition of trauma, and then think about that the idea of multifinality, right? Instead of ending up with PTSD, where they're re-experiencing a traumatic event, okay, now they're just kind of on edge and worried about everything. Okay, well, it's generalized anxiety disorder, or now they're worried about, they don't re-experience it so much like PTSD, but there was something present when they were really scared, and now whenever they see anything that reminds them of that one thing, that dog, okay, they have a phobic reaction, specific phobia. So these disorders don't just come out of nowhere. There tends to be a vulnerability, and then something has to happen, right? So if you have the vulnerability, but you have an easy squeezy life, then you may never develop the disorder. And again, important to keep in mind too that these disorders aren't things. They're simply diagnostic labels. Once the label is applied to you, will it always apply to you? No. Quite often people will stop exhibiting symptoms over time and no longer meet criteria, with or without treatment. Right? Remission of symptoms over time is pretty common. I'd say the one that's least likely to change, most resistant to change across time, would be the generalized anxiety disorder. Again, because it seems to be more of a personality disorder, where it's a way of looking at the world. Well, you're probably going to keep looking at the world that way unless there's some intervention, usually treatment oriented. But for the rest of them, oftentimes the symptoms will abate over time. Okay, that's all for now. Take care.